Those of you who've been here before, I generally don't read anything, but Sarah feels I have to have notes today because I forget at times something that she wants me to say. So, everybody's pretty well gotten their food, so why don't we go ahead and start. I wanted to thank all of you for being here today, particularly with the weather and so forth. I appreciate your coming out. We today celebrate a whole decade of PIPC, so we're happy that we've lasted this long, and we've only lasted this long because of the support and efforts of those of you in the room, and we appreciate it very much. We've come a long way in these last 10 years. When Senator Ted Kennedy asked me to lead PIPC, you don't say no to Ted, so I said yes. And he and I knew at the time that innovation and advances in healthcare were going to present challenges and opportunities for patients and policymakers. And my whole concern is with patients, and Ted knew that. Some of you may remember the tug of war when PIPC was created. That was a huge fight, educating folks in our community, and then working with House and Senate members made it difficult. But we put together something that helps patients out, and that's why I was so involved. And without, have they had their announcement already?
I
About
don't
what's in
know.
the bill?
No, not yet.
Not yet?
We're hopeful.
We understand, I stress understand, that there's some good news coming out on PIPC within a few minutes. And so I'll just tell you that what we understand, the most insignificant thing, is that it looks like it'll be a 10-year extension, which was our primary goal. There's a lot of other things in it that you'll like, maybe a couple things you won't like, but the 10 years for me is everything. So I hope that's what they finally announce. When we started, we've had people on the right, far right I would say, opposing comparative effectiveness research because they thought it would undermine doctors and lead to payers limiting choices. And then we had those on the far left who wanted PIPC to do both CER and cost effectiveness and wanted it used to limit coverage, which we were definitely opposed to. Patients, of course, were put in the middle then, and as a matter of fact, to a great extent, we're put in the middle again right now. And we are sort of, over the years, been the ones that are left out. As I say, the significant thing with PIPC is that for the first time, and in regards to our community, patients are at the decision-making table instead of in the outer room, and people say, what do you want? And they go into the decision-making room and make a decision on what they want, and we're not there to argue our point. The reason that this is so important is that we as patients react differently to the same treatment. I experience, as some of you know, epilepsy, and there are all kinds of different situations with epilepsy and drugs and so forth, and what works for me doesn't necessarily work for somebody else. Ultimately, patients won when PIPC was created to help patients make good decisions and not limit their choices to one size fits all. The thing I constantly say all the time is that no patient is average, and that's a key thing in the fights that we're having. Ultimately, today we are sitting with a very similar debate that's creeped up on us that again puts patients in the middle. There are proposals in Congress and at the administration to make the U.S. health system look like the United Kingdom or Canada. I would propose that, as with most things, we need to find the unique American solution to drive healthcare affordably. Today we are going to focus on this debate around international reference pricing and what it means for patients and people with disabilities. In other countries, they view a person with expensive health needs, people with disabilities, and serious chronic conditions as not being worth treatment. As a result, outcomes for people with cancer, cystic fibrosis, and other disabling conditions are not better, they are worse. Today we will view a video about a family in Canada that has been subjected to a health system that only treats when it is viewed as cost effective. Sarah was going to have on the tables for you some tissue paper because this is going to be a very sad video, so use your napkins if you need to. Thank you to Siri and Dr. Bailey and Christina for providing your reaction to this video from a personal experience. I'm excited that we also hear directly from Anna at the National Council on Disability. You'll be impressed with her presentation. The NCD took over a year researching and publishing a report about the quality adjusted life year metric often used by other countries and its implications for discrimination. Our last panel will also include Joel White and PIPC steering member Sue Peshin, who will share their experience on the potential implications of importing international prices to the United States. If we have time at the end, I'll ask for some questions. Sarah and Tara, go ahead. Let's take off.
Great. So now we're going to see the video. Thank you, Tony. What would we do without Tony? Here it comes.
I am a wife. I have 2 children. My son is 14 years old, and he's a healthy young boy, and I have a daughter who's 13 years old, and she has a chronic disease. Laura was diagnosed around 1 month of age. She started having like this big swollen abdomen. We weren't sure what was going on, and her pediatrician tested her for cystic fibrosis, and it came positive, and kind of rocked our world a bit. We were not expecting it. It turned that we now have this disease that's we knew enough about that is going to shorten her life, and that was going to require a lot of treatments for the rest of her life. We don't have the most cutting-edge treatments available. We have them out there, but they're not accessible. And I find that really difficult because of the way the policymakers are not allowing them to be accessible for her or for any other people that need these type of rare disease strategies. There's 2 more drugs that Laura could actually potentially get, and she has to fail on Oricombi in order to possibly get another drug medication. So it's always feels like you're always failing to get something in order to try to get the next.
Give it a moment. Technology is wonderful. Buffering. So are we gonna, is this, I mean, we could.
Chance, and she doesn't have the time anymore, and and we're not seeing that. So the criteria for the access of the drug that Laura is going to be receiving, or Combi, she had to drop her lung function by 20% in a first 6 months. So and retain this drop for 6 weeks. A lot of physicians found that a very difficult process, because if somebody drops their lung function by 20%, they're hospitalized and they're getting treatments. They don't want to keep letting it drop, because then it's a higher risk they're not going to get it back. And so for Laura to maintain that drop for 6 weeks, it's very unrealistic, and the restriction is so tight that actually nobody in Canada has qualified for this criteria. Laura is the only one in Canada that has qualified, and that's actually not a rah-rah thing. That's a very sad thing, that we had to watch our daughter get sick and maintain being sick for 6 weeks. We were on pins and needles. I wanted her to get better, but part of me didn't, because then she wouldn't get the medication. And to sit there and watch her, and she was terrified. I remember she has to do a blowing test, and in order that gives you the value. And she goes, "What happens if I get better? What happened? I won't qualify." She was so scared, and I said that is the worst feeling for anybody, that they actually have to fail something in order to get something. We're thrilled that she's finally getting the medication, but we're also really sad because she has now gotten so sick that the doctor told us that if her lung function drops down even further, the drug doesn't work as well, and half of the patients have to be taken off the medication and then progress to lung transplant. And Laura right now is getting the lung transplant assessment. We're moving forward with that. And that's really heartbreaking, because 2 months ago, they had so much hope that this actually could have sustained her from having that, and now we have to look at this. So as much as, yes, we're very excited that, she's finally getting a chance, and Laura's really thrilled, because that's all she wanted. She just wanted to give this drug a try to see if it will help. And now knowing this, we're kind of like, oh, is it going to work or not?
So I've seen this video several times, and every time I get verklempt. It's a very, very sad story. Before we get started with the panel, I just want to say thanks to everybody for being here, and to Tony for bringing PIPC together in the first place. It's been a wonderful journey. Really, focusing on comparative effectiveness research, now thinking about how we value treatments. How we do that research to value treatments. And in this forum, I think, I know it seems like a complicated issue, but it's connecting the dots between a lot of these policies that have been, that are being promoted in terms of international reference pricing, and having a better understanding too about what actually happens in these other countries, and thinking about how they value treatments, and think about how they're going to coverage and reimburse for them. And then, the larger question of, do we want to do that here in the United States? So first, we're going to start with a panel to react to the video. We're very excited that we've got Siri Vyeth here, who's the Executive Director of the Cystic Fibrosis Research, Inc., CFRI. And she became first involved in that organization in 1995 after her daughter's diagnosis with cystic fibrosis. We also have Dr. Lakia Bailey, who is the Executive Director of the Sickle Cell Community Consortium, and she's going to be providing us with a patient perspective to this video. She's a sickle cell disease advocate, educator, and a research scientist, so thank you very much for being here. And then Christina Hartman, who recently joined the Assistance Fund and came from Every Life Foundation, which some of you may be familiar with, where she led policy and advocacy efforts to advance treatment and diagnostic opportunities for rare disease patients. And Christina has a daughter with a rare disease as well, and so their perspectives, I think, will be really, really useful to us as we think about what does this mean for the United States. So I want to ask first a question to all our panelists, and Siri, I'll start with you. What is your initial reaction to this video, and how would you feel if the U.S. adopted a similar model of healthcare? And I mean, having a daughter with cystic fibrosis, this one must kind of hit.
That resonated with me so incredibly deeply. to think, I mean, anybody who's in the rare disease community knows that only 5% of the diseases have any kind of therapy. So here we have this therapy, and it is not a cure, but it is something that can stop what is an inevitable lung function decline. Everything with CF is about staving off lung function decline and death. And to actually have a policy where a person is almost forced to decline by 20%, and quite often that is just irrevocable damage. And there are so many other symptoms and problems that come along with this at the same time, is to me just unconscionable. It's unbelievable. And I have to say, my daughter just turned 25 this week. To think what it would be like to watch her going through that, with all the exacerbations and hospitalizations, I would be terrified, because we all know too well, I was actually speaking with a woman at my table, CF is very capricious, and one bad infection can create what is the death spiral. You cannot get it back, and we are still losing people at a very young age. So for us in the US, nobody's going to say that we have a great system, but there is access to that drug and access to the next generation of that drug. And now we actually have a third generation of that drug. Unfortunately, I do feel like in a subtle way, that kind of thinking is creeping into our healthcare system. As anybody knows, for any of these specialized medications, it's all about a very arduous pre-authorization process. And quite frankly, every day does matter. So we have such a hodgepodge insurance company here. I would say the combination of legislation from the Americans with Disabilities Act to HIPAA. Most people think of HIPAA with the P being of privacy, but it's portability and being able to get insurance when you have a pre-existing condition. Then on to the Affordable Care Act. We have these things in place that are so important, but we really need to be vigilant as disease groups, because I'm terrified that that's what's beginning to happen here.
Dr. Bailey.
Absolutely. So this video in and of itself, I thought the mother described it as discouraging and disappointing. To me, I think I would go a bit further and call it cruel. Mm-hmm. The reality, though, however, is that for sickle cell patients, many of us are already in this point where drugs are inaccessible. They have been made economically inaccessible. Mm-hmm. And many of the newer treatments, the best way, gene therapy, bone marrow transplant, even the most recent ones, the best way to gain access was to do it through a drug trial. And in order to be part of those trials, for many of them, you have to be sick enough. And so for my case, I've considered bone marrow transplant as well as gene therapy. You have to have gotten to a certain baseline of sickness in order to qualify for many of those trials. However, if you do get a bone marrow transplant, it is not going to reverse the damage that's already been done. So I have to let my body get damaged enough to be able to access this treatment. And that treatment helps me going forward, but does nothing for the end damage. And so I stand by the statement of it being very, very, in my opinion, cruel. I do understand the reason behind of it. I get the science. I'm a scientist, and you do not want to necessarily subject someone to a certain amount without knowing that it is almost a last option in many cases. The Canadian model, there's quite a bit more to the model than what we saw here. But for this aspect of it, we're already living that in some ways in the sickle cell community. And that inaccessibility, be it either economic or having to sit at a baseline where your health has dropped so badly, it creates this scenario where I've had people come to me and to say it's almost as though they don't just want us sick, they want us destitute. We have to be to a point where we can do nothing for ourselves before we can access care. And it's concerning. My heart breaks for this mother and for her daughter to be afraid that she's getting better. That's not a scenario you ever want to put someone in, where you don't want to get better because you want to be well. And better should not be the enemy of well. And that is the situation that I think we often find ourselves in. So the video concerns me. There's very strong evidence for the negatives of the model in Canada and the UK. There's also strong evidence for some of the positives as well. And so, as was said, I think we do have to find our unique in between. We have to find our way so that we can stop putting patients living with this disease, with all kinds of diseases, in a scenario where we have to almost hope we get sick enough to die, but not quite die, so that possibly we might have an opportunity of getting well.
That's just heartbreaking to think about, yeah. Thank you for that. That's really helpful. Christina, tell us a little bit about your reactions as a parent. And
yeah, so my reaction to the video, and honestly, since I came into the rare community just a couple of years ago through the diagnosis of my youngest daughter, has just been shock. I think Tony said it best, and Dr. Bailey reiterated the importance of having a unique American solution to all of this, because that's what we do best. But I've spent the past 20 years in Washington, and I always thought we were doing okay until I had my youngest daughter. And, I live in Montgomery County. We have some of the best services in the nation. And I live 2 blocks from the NIH. I started my career in the Secretary's Budget Office over at HHS. I've seen, how we allocate resources. I've seen how much we have. And yet I spent a year beating my head against the wall, even trying to get a diagnosis. And so I think, as we all know, the average time for diagnosis in the rare disease community, which is an estimated 30 million Americans, it's a huge public health crisis when you take it collectively. The average time to diagnosis is 5 to 7 years. Mm-hmm. Many of these children are dying before or by their 5th birthday. And one of the challenges we have are these barriers that are put into place. Access not only to treatments, but to therapies and diagnosis is a critical issue in America right now. So my geneticist at Children's National spent a year with me behind him fighting my platinum insurance plan to have a whole exome sequencing, which was finally definitive for my daughter. And for many folks in the rare community, that's when you'll finally get a diagnosis. For many of the girls with my daughter's genetic disorder, they're getting diagnoses later in life, which means they're not getting access to therapies. There is no treatment right now. Like Siri said, 95% of the rare community doesn't have an FDA-approved treatment. But for those that don't have the treatment and need these critical therapies, if they don't get the access, I met recently a 6-year-old with my daughter's genetic disorder who cannot even stand independently. These girls are all nonverbal. I met a girl in Orlando with her disorder who's 8 and had such severe epilepsy, and epilepsy is often one of the most common comorbidities in the rare community, and it's degenerative. So like we're hearing, as you progress, you can't go back. And so this little 8-year-old girl had to have a surgery to separate the hemispheres of her brain. So when you don't have that early intervention, when you don't have, whether it's a treatment, a therapy, things like speech therapy, occupational therapy, physical therapy, if you don't have that early and often, your outcomes are not what they could be. And so as a parent, the most appalling thing is we are the wealthiest nation in the world. This is, to me, the greatest country. I've been to many countries. This is by far the greatest country in the world. But we need to put those who need us first. We need to put the children first. They need the right resources. We should be investing in treatments and cures and access to care. And the most appalling thing is with that video where you see a child, and Siri said it best, who there is a treatment that exists and she thinks she has to get sicker to access it. I mean, as a parent, that should break all of our hearts.
And
thank you.
And I just want to
Keep
add,
going.
what you can't quite grasp from that is that somebody has made the decision that is completely divorced of humanity. It's, you know what, she's going to have this many lung infections that are going to require hospitalization. She might have a hemoptysis where she has spontaneous bleeding into her lungs. She might have a pneumothorax where a hole pops in her lung and her chest fills with air. And then she might still get a transplant, as we saw that she's now being listed. That's still cheaper than the cost of that drug. So we think we're going to torture this child and possibly cause her death, it's cheaper, it's more cost effective than actually giving her that medication. So that, I think, is what horrifies me about what we're increasingly seeing, is this taking away of humanity and really reducing things to a cost and weighing the benefits of, it's more expensive to have a drug than to actually have a person go through, the hell that is all the exacerbations related to the disease or diseases.
Thank you. It's a tough video to watch, right? Dr. Bailey, you mentioning your own experience. In sickle cell disease, up until recently, there have been very few options. Talk about your experience as a nonprofit. I mean, it's your job to help serve a population that has extensive unmet needs, as you just described. So, tell us about that experience and about, in terms of the direction that we may go as a country. What do you then see for how you serve that population of patients that have such an unmet need already?
So it's been an interesting year. A couple of years ago, we had an FDA-approved treatment to come out, which literally doubled what we had available to a whopping total of 2. And in the rare disease space, that can actually be a miracle. There are, 90% of diseases that wishes that they had 2. In the past year, over the course of 10 days, that doubled again to 4. There were 2 more FDA-approved treatments. And so this past month, in the space of 10 days, we doubled the number. We are still, however, quite limited to accessibility, and it has become economically inaccessible for many, many patients to access these treatments and access these cares, and so, these therapies. And I think that puts us in a strange spot, because here we're seeing where a group have divorced the humanity, as you mentioned, and are making decisions based on the cost. There was an article that came out in the New York Times recently that our sickle cell community reacted to quite strongly, because the tone of the article was essentially, are these patients worth the cost of the treatment? And so it was incredibly tone deaf. There was a lot of inaccuracies. I asked several people, do fact checkers not exist anymore? Is that not a thing? Because there was quite a few just blatant false things in there. Our community reacted to a specific part very strongly that I think may be a mistake, because we do have to look at the entire piece. And it was, apparently they quoted a physician that talked about brain damage as a side effect of sickle cell, and that patients may not even have the ability to make these type of decisions for ourselves, which was horrifying. And it was just, that was a bad piece, but I think the overall article is talking about the economic inaccessibility of these drugs. And in our country, it is a very different economic sorting system, whereas opposed to a small group making it for the general population, there can be no better and more cruel, honestly, sorting system than that which divides people based on their zip code. You can access this care, you are worth this care, depending on how much money you have in the bank. And that is, to me, equally as horrifying. And so, where do we go next? So my nonprofit exists, we operate a little bit differently in that we are a network. And a network of patients, caregivers, and community-based organizations that come together to define problems, define needs, define gaps, and then figure out a way to collectively address them. In the sickle cell community and in all rare diseases, when you are living with a rare disease, you are often taught of all the things that you can't do, you shouldn't do, you can't, helplessness. And I say it all the time, helplessness is learned, and it has to be unlearned. And so in the sickle cell community, we reject this concept of learned helplessness, define the problems we want to address, and somewhere in this community, there is a patient or caregiver living with the disease that has expertise in every area, including economic assessment, value-based assessment, treatments, and care. There are people in our community that can have these conversations. My goal as our nonprofit is to identify these people and then to encourage every single table that exists to ensure that a patient or caregiver is at that table, helping to make these decisions, because you cannot divorce the humanity. You can tell a lot about a nation by the way it treats its most vulnerable populations. And you cannot hope to grow as a strong and powerful and great nation if your vulnerable populations have no voice in the decisions that affect them. And so that is what we do, and that is my goal with moving forward, to ensure that we are at the table. And I had a conversation just this morning that there are some tables perhaps that if we are not at that table, or maybe tables we shouldn't be at because they're going about it in a way that does not affect our population or doesn't, maybe we should remove the table and have a picnic and still get the work done. And that is where I see our population and all rare disease individuals moving forward. If they will not make a seat for you at the table, get rid of the table. Create a picnic. Bring your own dish and get it done. And that's how I see us needing to move forward in all of these spaces. We have to ensure that the voice of the vulnerable is the loudest voice in the room. And so, as I mentioned, I think that there are some positives for these models that we see, quite a few of them. Should a small group without humanity be making the decisions for the groups? Absolutely not. But neither should your zip code determine the amount of care you're able to access. So we have to find a way to do that, and do it in a way that we ensure those living with those diseases, it's their voice being heard.
So you said something that caught my attention about that article. Were you contacted, or was anybody in the sickle cell community contacted for that article? And I wonder, just in general, from the rest of the panel, like, to what extent are your voices even being solicited when articles like that are being written, or value assessment processes are happening, or insurers are looking to determine how they're going to cover treatments? Like, how to what extent do you feel like the community with the disease that you're focused on, or a rare disease, are consulted?
I think that for sickle cell, so no, for this particular article, I was not contacted. I don't know, I haven't heard from people that said that they were, and they were part of it. And based on the way the article reads, I sincerely doubt anyone was. Mm-hmm. Honestly, I don't even know, let's just not go there, but it's a horrible article. But in general, what I have seen is that it's beginning. So NHLBI has Cure SCI initiative. It is the Cure Sickle Cell Initiative. And it has been put together, and a team of individuals have been put together and tasked with helping to find a cure for sickle cell in the next 5 to 10 years. It's divided into several subcommittees. One such subcommittee is focused on this, on value, on pricing in sickle cell. What would these new treatments and therapies mean? What I have learned is that, and they asked me to sit in on that subcommittee, so I'm part of the executive committee, and I am able to sit in on multiple of the different. They asked me specifically to sit in on this subcommittee, and they are reaching out to patients and caregivers. I've asked them to ensure that a patient or caregiver is in the room at those meetings. So there are pockets of that happening. Often what I have seen is individuals or organizations who are focused on this initiative reaching out to the community, and not just sickle cell. I've reached out to multiple different disease groups that I've seen the same pattern that's now happening in sickle cell has happened before. And what they have told me is that some groups, yes, they reach out to me, we give them our voice, and then it's disregarded. And that seems to be a repeated narrative. Or they are reaching out to certain organizations saying, yes, we want you to help us to get the patient voice, but it's done in such a way as though it is thoroughly edited. Okay, that's the voice we want to hear. And so it isn't, I don't believe it's true. It's not a real and true effective way of engagement. It is what has impressed me as tokenism engagement. We can say that you were part of it, but you're not part of the solution.
Yeah. Yeah, Tony and I we talk a lot about tokenism at PIPC, and Christina, it's similarly. Do you feel like, I mean, yeah, I guess I'm trying to get to what extent voices, the real voices that are impacted by these policies, are being consulted.
So in the time I've been in the rare community, you know, I've engaged with a lot of parents and parents of children with terrible diseases where their children are dying. Time is of the essence. The one thing that is consistent across the board that I can't believe we're having such a challenge with is that their lives have value. I didn't even know that was a question until I came into the rare space. But what I hear from the parents consistently is that there are groups that are making determinations about what is the value of certain treatments or therapies. They're making them in a room without consulting the parent groups. And even just in the past several months, what I consistently hear is that these groups are now even being banned from participating. These groups will have meetings, they'll convene, they'll have a discussion, and if the parents are allowed in the room, the groups making the decisions will sit with their backs to the parents. So they can't even see them, because apparently that would sway the decision making. And now they've resorted to not even letting the parents into the room, which to me is appalling. I don't understand how we can make decisions that wouldn't automatically take these people into account and automatically just say, of course their lives have value. I mean, isn't that one of the key underpinnings of our society, that all lives have value? So to me, that's just where we need to start from, and we're clearly not there now.
So Sarah, you went through a review, a value assessment review that was conducted by the Institute for Clinical Economic Review. And do you want to talk to us a little bit about your experience going through that review? And to clarify, ICER uses a metric called the QALY, which we're going to hear about a little bit more later. But I'd love to hear more about what your experience was going through that process.
It was bad. Thank you. No. It was utterly dehumanizing, and I will say that we are in the process of going through this yet again because of this recent FDA approval of a triple combination therapy. So we are in the thick of it once again. I was quite appalled by the entire process. I will say when they first were assessing these two other, the Orkambian and Symdeko, they did their draft scoping report, and in that report in which they said, oh, it looks like it has great value, it has great effectiveness. It actually does reduce exacerbations requiring hospitalization and IV antibiotics by 50%. It does this. It seems to improve quality of life. Not that that was a measure for the clinical trial. But it is not worth it. That was the final report. Now, in this report, they listed a series of CF-related organizations, CFRI being one of them. Now, we are similar to, it seems, the sickle cell community. We are bonding together because together we have a much louder voice, and so we have a cystic fibrosis engagement network with about 5 or 6 other CF-related nonprofits. And we were all listed as stakeholders that they had consulted with and engaged with to create this draft scoping report. And we felt so violated because we opposed the results of the report. We opposed the concept of why that report was even being made. We opposed the notion of this group believing that they have some capability to act in the end, like God's on high, determining life's value. And there our names were listed as stakeholders as if it was a tacit approval of the results. So they then had their meeting to vote on whether they would accept this report. And yes, I was at that meeting where I walked in and there was the horseshoe of the members of ICER. And behind the panel was, the lone mic on the pole. And everybody, if they wanted to listen, had to do the body contortion to turn around. So many people did not do that. And during this hearing, they're presenting all the results and all the positives that these drugs have led to. And literally, renowned pulmonologists saying, any day you stop the progression of lung disease is a win. They were looking for 20% bump, 10% bump in lung function, when it is inevitable. The arrow goes only one direction with CF. And so here's this drug that for some people bumped, but for others stopped the decline. And it wasn't good enough. And you have impassioned pulmonologists, which I will also, this is terrible because I could go on for hours about this, but when they do their assessments, they purposely do not bring on a specialist in that area. So they did not have a CF pulmonologist as part of the review process. And I was sitting between a father whose son is about 12, who was on a significant health decline until he started that drug, and his life had changed, and next to a man with CF. And they're watching these charts, and my friend Mike, who has CF, said, oh my God, there's my life just split out as a bar chart. There is my value. And in the end, they did vote unanimously that the drugs had effectiveness in terms of disease progression, but unanimously voted it was not worth the money. And so just not worth the price. And you know, this sounds very petty that I would add this, but I will say when I was outside waiting for my Uber to fly back to California, one of the members of the panel came out and she said to me, well, that was fun. And I thought, okay, that pretty much summed up the whole process. So now we are in the midst of going through this process yet again. ICER is engaging with the CF community because I think they were publicly shamed about their lack of engagement last time. But I have to say, and I would expect that for what you've been going through, it is somewhat of a dance. Because again, I don't have respect for this group and its principles. I do believe they divorce humanity from the whole process, which is impossible. To say nothing, they're economic. If you just look at economics, they don't include anything else. Caregiver lost wages. I can tell you I lost weeks and months, collectively months of time working when my daughter was hospitalized. They don't take into account adults with CF and their capacity to work and add to. They don't take into account other expenses related to the disease. So even if you just look at their numbers, not the humanity, that's flawed. So now we are engaging with them because we feel if we don't bring our voices, we will not be heard. And sadly, they are supported by payers. Payers have a vested interest in what they decide. And so it is this perpetuating cycle. And we need to speak up to include the broader implications of our diseases so it's represented. But as I keep saying to them, I will engage, but it really is under duress. I do feel like you are taking so much of my professional time that I could be out there providing services, raising money for research, responding to this process for which I have no respect. I mean, for which I find is not authentic. I do truly still feel like there's tokenism with the engagement. So that was a much longer answer than I think you were looking for, but
I think it's very
disturbing.
Helpful. You know, I mean, we're focused on what it would potentially mean to look at other countries as the model for the U.S., but what other countries do is that they use organizations like ICER to determine cost effectiveness and then translate that into their systems in terms of what is covered and what is not. So, and I'm curious, Dr. Bailey, because sickle cell treatments are going through this process with ICER now too. So how is the sickle cell community responding to it and you know, and thinking about it in terms of what that means for coverage and access?
I think that what I've seen, and again, so we have become, it looks like, one of the focuses of ICER moving forward. We've not had the experience of going through it before, but having had conversations with and other organizations that have, it seems to me as though there has been this push towards this tokenism engagement. And other disease groups that I've spoken to unanimously have felt that way. I have not yet been introduced to a group that has said, oh no, they heard us, our voices were included into what went out there, and I've spoken to several now, and I've not yet heard that. To me, I struggle with engaging with them at all. Mm-hmm. And in doing so, I understand that in our community we have this where we want to be included, and I think sometimes that goes wrong for us. We're just so glad to be included that we're okay with being used. Mm-hmm. And that's the difference there. And that's what I've seen a lot when you have a group that has been overlooked and disregarded for so long that now I have a voice at the table. You really, really don't. You're a shadow in the room. But if it seems as though there's a voice at the table, well, then I'm just so glad to be included. And when you want to be the face of it, and you want to be out front, and you want to be included, that can go wrong. And so we're working with PIPC and different groups, NMFQ, and just all of these different ones to work on this and to figure this out and to make sure our patients are educated on what ICER is and what it is not. This is not a convening organization. This is not, and I think that has gotten missed in the education that's gone out, and what has happened with our community is that we've missed what it isn't. And there was this push for urgency that went through with ICER and sickle cell not that long ago. And in the process of pushing urgency for an ICER-created deadline, there was a lack of education. Oh, we have to respond, we have to do this, we have to do that. And I personally, even with this article I mentioned a moment ago, I prefer a thoughtful response to a timely one. If it takes a little bit longer, but it is thoughtful and that you have put it together. And so I struggle with engaging with them at all, because what I don't want to do is give the impression, which it sounds like is what happened with you all, give the impression that we were part of this when we weren't. We were shadows in the room, and then you used our names. I don't want to draw more attention. I don't want to create a crowd, an audience for this panel. I'd rather the panel speak to the walls. And I know that they have people that are listening to them and engaging with them. And so I struggle with, do we engage with them, or do we figure out a way to go around and above them entirely? And I've been talking with lots of experts in this space, because I'm not sure that it makes a lot of sense when there is, I've said this, and I give all these random analogies. To me, ICER is a molehill attempting to cast the shadow of a mountain. But if you look only at that shadow and you only see the mountain, you don't realize that this molehill, perhaps it's just a matter of stepping over it. And how do we do that, and how do we do it effectively? How do we engage without giving them more authority, without gassing up this? That's my question. And how do we do that in such a way so that our voices are heard, that we're part of this process? There are groups like the one QRCI is putting together that has people at the table that are far better equipped for this conversation than what I have gotten from my impression of ICER. So what's the answer? What's the solution there? And I can't give it to you. I don't know. But we're trying as a community to figure that out.
Christina, do you think, having been in the advocacy world for a while now, do you think that people outside of Washington, D.C., like patients, advocates, just real people struggling to get access to treatment, do they understand this debate that we're facing in this country around international reference pricing, cost effectiveness, what that might mean? Like, are they engaged in it? Do they understand it?
Right. So yeah, it's funny. I've been in the Beltway for 20 years, which is about half my life. And I think that what happened with Charlotte, my youngest, has really changed my perspective, because I have engaged at a professional level with people outside the Beltway now more than I had in years. And the folks outside the Beltway are some of the most resourceful, pragmatic, smartest people around. And what really resonated for me in the video was when the mom said that the policymakers are not allowing access to treatment. And so we see that a lot in Washington. The policymakers can either facilitate access, or they can be a barrier to access. So one of the things that I'm hoping to see, in the coming few years is I want more of a reliance on the patients. I want to see the patient voices, like Siri and Dr. Bailey have brought up. They should be leading the discussion. They should be the folks that are the center of everything that we do. It all goes back to the patients. We can make policies in Washington, we do this day in and day out, but unless you've truly incorporated the patient voice, unless they're at the center of everything you do, we're not really gonna make progress here. And so one of the things I think you know, Sarah, that I recently went to the Assistance Fund, and we are one of the charitable assistance organizations. So we ensure that patients have access to treatments. We would love to see our organization and all others like us go out of business, because we would love for them to fix the healthcare system and ensure that there is no need for assistance with copay, with reimbursement of insurance premiums, with assistance with medical incidentals. But unfortunately, in the current situation that we're in, we got to keep doing what we're doing. So we will continue to do that. We are now here in Washington. We just opened our DC office. We are going to be working with patient groups across the board. We have 62 different disease funds, and we are going to ensure that these patient groups and these patient voices are heard and listened to by policymakers. So that's what I would say about outside the Beltway.
Thank you. Well, so we are going to wrap this panel up, and I want to say thank you to all of you. Your answers were spot on, I think, exactly what we wanted to hear from today. Thank you. While we transition, we're going to show another short international patient video, and we'll be bringing up our next panel while we have that video playing. Thank you.
Our mother was diagnosed with multiple myeloma. It was a time of lots of uncertainty. It was quite difficult because in that time there wasn't much for myeloma. Over time, I became totally involved in patient advocacy. It's very complicated, it takes time, and it causes delays actually in patients getting access on a reimbursement level. I can't accept that someone can't get the basic, even generic drug in a European country. That's not acceptable.
All right, so we'll call up our second panel. Thanks to everybody for staying with us. Hopefully we'll still be able to end on time, although in typical PIPC fashion we might go a few minutes late, which is fine. But the video that you just watched, I think, is just sort of another reiteration of some of the challenges that have been identified in other countries that we're excited to be able to talk about today. So I'm going to provide just a very brief introduction of our next panel and speakers. So first we have Ana Torres Davis, who is an attorney for the National Council on Disabilities Policy and Legal Team. Her career has been devoted to civil and disability rights, and she's worked at the Department of Education and Housing and has now brought that expertise to the National Council on Disability. She's going to be doing a presentation for us on a recent report that they published on the Quality Adjusted Life Year. We also have Sue Peshin, who is the president and CEO of the Alliance for Aging Research, which is the leading national nonprofit organization for accelerating the pace of scientific discoveries and their application to improve the experience of aging and health. She's also a PIPC steering committee member and is invaluable to me in that role. Joel White is an old friend, president of the Council for Affordable Health Coverage and its campaigns on transparency and medication adherence. He used to work on the Ways and Means Committee back when I was working in the Senate. So Joel has a long background working on things like Medicare reform, and I think this will be a really interesting discussion. So Anna, we're going to start with you if you don't mind. So we're going to let Anna take the floor for about 10 minutes to provide an overview of the National Council on Disabilities report.
Great, thank you so much. Can you hear me okay? Okay, well, thank you for having me. For those of you not familiar with NCD, we are an independent federal agency that advises the President, Congress, and sister federal agencies on disability policy. NCD's report, Quality Adjusted Life Years and the Devaluation of Life with a Disability, is part of a 5-report series that we have done on the intersection of bioethics and disability. And it focuses on how the historic and continued devaluation of life with a disability by researchers, the medical community, legislators, even health economists, has perpetuated unequal access to medical care for people with disabilities and even life-saving care. And NCD undertook the examination of QALY's impact on people with disabilities and chronic illnesses. And of course, we're talking about one and the same. When I say disability, I mean chronic illness as well. Because of the long-standing concerns about and opposition to the use of QALYs that were brought to us by the disability community, by advocates, by patient rights organizations, and by bioethicists. We wanted to know if QALYs did discriminate. We wanted to know if they did, how they did it, and what were the ethical implications of their use. To inform the report, we did a comprehensive literature review. We had a stakeholder convening in September of 2018. We talked to diverse experts and stakeholders, all that had knowledge of QALYs and how they impacted people with disabilities. And we found that many stakeholders from the medical, health economics, and health insurance fields believe that QALYs are not discriminatory. They recognize the aspects and the ethical issues with it, but they stand by the fact that they believe that this is the best way for them to provide information to payers about the benefits and costs of different treatments and drugs, and to help them negotiate reasonable prices with drug manufacturers. But NCD found sufficient evidence of QALY's discrimination to warrant concern. NCD found that the United States, well, I'm going to just go over our findings with you now. We found the United States does not have a single comprehensive policy on the use of QALYs. We know that the Affordable Care Act prevents or prohibits Medicare from using QALYs. At the same time, we feel like there's enough ambiguity in some of the provisions of the Affordable Care Act that we really want to tighten that up and make sure that absolutely they cannot use it. Some Medicaid programs do use QALYs, and that's very problematic. And that QALY use and interest in the use of QALYs is growing in the United States, which is a concern. We know that because of CMS's advance notice of proposed rulemaking, and we know that because CVS Caremark's new agreement with ICERS. NCD's research supports the claims that QALYs undervalue treatments that extend or improve the lives of people with disabilities. Because the QALY calculation reduces the value of treatments that do not bring people back to a state of perfect health. QALYs rely on simplified assessments of value that don't accurately reflect the patient experience with disability or illness. We found that QALYs typically evaluate the worth of a life with a disability based on the preferences of people from the general healthy population. And this is problematic because most of the people that are giving these preferences do not have disabilities, and they do not have the correct information about disabilities to make these judgments. The fact of the matter is that we have tons of research showing that if you ask the general healthy population about disability, they will consistently rate it lower, the value of life lower, than would people with disabilities. But the practice continues. Now, our interviews and our meetings with bioethicists, they tell us that on ethical and moral grounds, some bioethicists believe that the use of QALYs are discriminatory, that because by favoring people with no functional limitations, let me find my notes, I'm sorry, that QALYs implicitly endorse the belief that the lives of people without disabilities are more valuable than the lives of people with disabilities. And I think that's the theme and some of the core of what we're talking about with the QALY. They argue that the use of QALYs will lead to a situation where funding treatments that extend the lives of people who can be restored to perfect health will be valued over those treatments that extend the lives of people that cannot be restored to perfect health. And in fact, we're seeing that in other countries now. And that it is morally unjust for QALYs to lead to the prioritization of the former over the latter, and that the United States should not adopt policies that violate a person's right to be treated as the equal of any other person in society. But a clear indicator of the discriminatory result of the use of the QALY comes from nations that use the QALY on a regular basis. For example, and I think that some of you in this room know this well, QALYs are a key metric used by the United Kingdom's NICE. Now, the primary purpose of NICE is to decide which drugs and treatments will be funded by Britain and Wales National Healthcare System, or NHS. To do this, NICE analyzes how cost-effective each drug or treatment is by calculating the treatment's cost per QALY. NICE's reports are known to reduce patients' access to care. So if you remember anything from me sitting up here today, their reports are known to reduce access to patients' care. We have a group in the United States called ICER that issues similar reports. This is particularly likely to happen to patients who have a complex condition that requires intensive, expensive treatment in order to manage it, which describes many people with disabilities. For example, NHS patients lack unrestricted access to the majority of cancer treatments on the market. According to a 2018 study, between 2013 and 2017, NICE recommended access restrictions to 70% of the available cancer treatments that it looked at, and it outright rejected 22%. In contrast, in the United States, somebody that has a diagnosis of cancer has cutting-edge treatments available to them right after diagnosis. NCD's position at the end of the day is that QALYs should not be used in the United States, and that alternative cost-effectiveness measures should be used that do not have QALY's discriminatory effects. NCD understands the need for cost-effectiveness. We understand some of the consideration of cost-effectiveness is reasonable in national health insurance programs with limited budgets, such as Medicaid. But we also know that adopting strict prioritization that's reliant on QALYs is contrary to U.S. disability rights law and policy. NCD's key recommendations for Congress, there are two: Congress and the Department of Health and Human Services. First, NCD recommends that Congress should pass legislation prohibiting the use of QALYs in Medicaid and in Medicare, and that it should provide funding to the Department of Health and Human Services to do research on best practices in cost effectiveness to inform benefits and coverage decisions in Medicaid and Medicare that do not rely on the QALY. NCD also recommends to the Department of Health and Human Services Office for Civil Rights that they issue guidance clarifying that the Americans with Disabilities Act applies to coverage programs that state operate, such as Medicaid. And specifically, we want them to issue guidance to the Centers for Medicare and Medicaid Services, as well as state Medicaid agencies clarifying that Title I of the ADA, Section 504 of the Rehabilitation Act, and Section 1557 of the Affordable Care Act apply to Medicaid programs and all health insurance programs operated by recipients of federal financial assistance. The guidance should specifically discuss how these authorities apply to benefits and reimbursement decisions, and that payment decisions should not rely on cost-effectiveness research or reports that are developed using QALYs. We also recommend that CMS utilize well-established alternatives to QALYs, such as multi-criteria decision analysis, which is a method that better acknowledges the complexity of healthcare coverage decisions, or cost-benefit analysis when the exact benefits and costs of a drug or treatment are known. NCD recommends that CMS refrain from pursuing means of reducing Medicare and Medicaid prescription drug costs that attempt to model U.S. pricing after the pricing in other countries that use QALY. And lastly, NCD recommends that CMS should rescind the advance notice of proposed rulemaking, which proposed an IPI for Medicare Part B.
Excellent.
Thank you.
Thank you.
So, yeah, I have to congratulate you on this report. It's a long report. There's a summary of it in your folders. But it is a really outstanding description of, QALYs are complicated, right? I mean, we've had several forums in the past where we've tried to explain the quality adjusted life year and how it works, and people start to glaze over pretty quickly. But this is an outstanding report for not only understanding the QALY, but understanding the implications of the QALY and how it's used. So I highly recommend, if you ever have, over Christmas or the holidays, if you want to, peruse this report. It's fascinating. So anyway, so I want to also, get to our panel discussion. So Sue and Joel, you guys know that there's this recommendation now coming out of NCD about avoiding international reference pricing, and knowing that QALYs are so complicated, I wanted to see if you could talk a little bit about how can we better explain this issue and communicate with policymakers and people who are making decisions about the QALY, because we've been talking about QALYs for a long time, but I'm not sure. Sometimes I worry that it's not connecting.
Mm-hmm. So I think just to take a step back, with the IPI stuff, I mean, I think this is kind of a false choice. We're talking about, affordability versus access, and I think if you look at several of the major government programs like Medicare Part D, we've been able to accomplish both. We've gotten more access for more people to more affordable medicine, so we have significant discounts through a coverage mechanism in Part D where we're getting this stuff, and we don't have to rely on a QALY or anything else like that, right? Where we're relying on a private plan negotiating a discount with a manufacturer. And so that's done really well in terms of promoting access. Now, we had to put some rules of the road around it in the law and ensure that there were all the drugs and all the categories and classes were covered, and that there were appeal rights, and there were those rules of the road, as I call them. But at the end of the day, we don't need to choose qualities or nothing, or have to march down this false kind of choice of affordability versus access. The problem with the IPI and how I think we should be talking about it is that what we don't, this is not like a theory or something that policymakers are discussing in a vacuum. We have ample evidence. We see this in England, referenced in the report. We see it in Germany and other countries where they're basically saying these latest cutting edge technologies are just not going to be available to patients, right? And that's how they're going to ratchet down on the cost of coverage. And like I said, I think that's just a false choice. So really honing in on the access issues, I think there's been a lot of data out there that shows that England's got about 2/3 of the new treatments available. Germany's got about half, and other countries like Greece have about 10%. So that's what you're giving up. You're giving up access to these latest medicines, and they're curative in nature, and that's what I think we ought to be wanting. The second thing I would say is that when we think about IPI, it's not like people won't get treatment. And I think what IPI does is it is a really good machine at sending people into the most expensive care settings. And so I think that we're not going to see savings from a straight IPI model because people are going to end up in the hospital where they're going to incur a lot of costs. So there's a better choice to do this. There's a better way to get better coverage and better affordability at the same time. Don't believe the hype. IPI won't deliver. How's that for a tagline?
I like it. IPI won't deliver. We'll remember that one.
Don't believe the hype.
Don't believe the hype.
Sue.
So I have a couple of other thoughts on ways to explain, and I really appreciated the report from NCD. I just thought it was exceptional. One thing I think sometimes is helpful is to understand the history of something, to understand the context of how it's being used. And with the history of QALYs, the application really began with the British use of QALYs in the 1960s, and it was purely used to ration care. And I think that that's an important talking point, is that the use of QALYs is for rationing of care. And at the time in the 1960s, there was a very stark increase in the number of folks who needed renal dialysis, and then there started to be use of transplantation. That technology was up and coming. It was incredibly expensive when it was first introduced, and Britain needed to find a way, how do we make sure that not everybody who comes along is able to get it, because we're going to go bankrupt if we do that. And so the QALY was introduced to sort of evaluate patients based on age and their level of disability, and that's what we're talking about, is you're evaluating the consumer rather than looking at the product like the drug. You're sizing up the person that's going to use the drug or use the procedure. And so that's a way to explain it as well. And then the last point I just want to make is with HR 3 and what just passed. I know the people with disabilities organizations and some of the disease-oriented groups went in and tried to visit with House leadership to explain this and talk about discrimination. And so some language was added to say, well, don't use any of this to discriminate. But there's a complete disconnect, because the policy in and of itself of using QALYs and using reference pricing is discriminatory. So they didn't take that extra step. So it doesn't matter to just say, don't discriminate. You really need that ban. And when you have the ban, it doesn't allow for IPI or any other policies that would use QALY. So that's basically how you lay it out from my perspective.
So that's very helpful. And so Anna, thinking about, again, this connecting the dots in communication, there are lots of reports that sit on shelves. How is the National Council on Disability pushing this out and making sure that it's used, that it's understood, and making sure that it's in the hands of policymakers?
Well, when we decided to do this series of reports, we knew the importance, and we decided that we were going to be very active in pursuing the recommendations that we are making. We have already met with the Department of Health and Human Services Office for Civil Rights. They were very receptive to the recommendations to their office about writing guidance and clarifying how QALY should not be used, and that it violates disability rights laws. We are going to meet with CMS soon. We are drafting them a letter, and we actually did write a letter, several letters that are on our website to HHS regarding this. The letter to CMS should be up soon, and that meeting should be held soon. We are educating members of Congress on this, and when they come to us, which they do, when there are proposed bills or they're going to take movement on something or they're considering something, we always weigh in. And we're going to continue to do that. We're going to continue to make presentations to concerned groups, and we are going to continue to spread the word about our report and our recommendations, and just hope that we can make the QALY as interesting and easy to understand as we possibly can. And I loved what you said, because that really clarified it very much. You know, when you look at it as a way to ration, that's really a great way to just start off a conversation, because we in the United States, we don't talk about rationing in that way. We don't have the systems that they have in Europe. So I think that I'm going to use that, if you don't mind, in our meetings with groups. But we will keep meeting with different agencies, and we will keep meeting with Congress people, and we will keep making these presentations.
Thank you.
Can I just add one last thing quick?
Yeah.
I do think that your audience matters. And so if you think of the two kind of folks who are pushing these policies, Pelosi and Trump, it's a different message, right? For Nancy Pelosi, it's more, this is just kind of strange from the party that has done so much to protect people with disabilities and, you know, access to services and products. For the Trump folks, it's more, you know, why are we importing socialism and price controls and price setting mechanisms from other countries? Why aren't we exporting capitalism and free markets and doing something to break down the barriers overseas?
That's a very good point, that our messages need to be nuanced based on the audience. That's a really good point.
Yeah, I completely agree.
You need to go to DOD and the VA.
DOD and the VA.
Calls, and that's just creepy. And you got to stop them there if you can. It's really important.
Okay.
Yeah, that's a very good point, Tony. So Sue, I wanted to also have you talk a little bit about the Vital Transformation Report, which talked about the potential implications of international reference pricing. I know you were very involved in that.
Oh, I wasn't involved in the actual study, but yes, Vital Transformation did an analysis actually of the Part B, Secretary Azar's proposal to apply reference pricing to Part B drugs. And this was before HR 3 came out and did what I call sort of IPI on steroids, which would expand it out to drugs outside of Part B and also outside of Medicare, potentially as many as a couple of hundred drugs. And I completely agree with what Joel said, just as before I go into the study. You know, that the folks that introduced HR 3 are the same folks that gave us the Affordable Care Act and prohibited this type of discrimination. So there is a bit of a disconnect. I know it looks very enticing. Other countries do pay a lot less. Folks wait longer to get access to things. Not as many people get access. And it shows up in the morbidity mortality data. So it has implications for health outcomes, and that's really important. The study that Vital Transformation did, though, really sort of debunked the impact on R&D and what would happen to innovation, because HHS had a certain model that they touted that it would only impact about 1% on R&D, but this study showed that one firm that had 3 drugs in the index would see an initial revenue drop equal to 23% of the entire R&D budget, with a loss of revenue in excess of $800 million. And another firm was closer to 10%. And so what does that mean? Because we don't all go, oh, boo-hoo, a pharmaceutical company is losing money. So I get the sympathy factor may not be there. But the fact of the matter is that companies traditionally spend about 20% of their free cash flow on R&D. So if you cut that, then you're cutting innovation, and that does impact patients. It also impacts potential savings for patients. So that's what this study did, is it sort of took a look at this impact just on the Part B side. And it's available at the Therapeutic Innovation and Regulatory Science Journal. Really good study, and something that I hope that the folks that are pushing for IPI take a look at.
So it makes me think on panel 1, we were talking about 95% of rare diseases don't have a treatment, right? So you think about what the potential implications are there. So in your folders too, there's a wonderful opinion that Sue did with the author of Vital Transformation, right? So anyway, that's in your packets too. It's a nice piece. So Joel, the Council for Affordable Health Coverage has been vocally opposed to international reference pricing proposals. And so can you just share with us a little bit about what their concerns are, because it's a pretty broad-based coalition, right?
Yeah. We have plans, PBMs, we have biopharmaceutical manufacturers, we have patient groups, providers, lots of employer groups. So every board meeting, I joke, I put my Kevlar on and walk in, and like flamethrowers start going off and stuff like that. It's pretty awesome. That's why I don't have any hair. No. So one of the things that we believe that unites us is that markets work better than government price setting. And if you think about IPI, it's really government price setting more than anything else. And let me walk you through it, because it's kind of nuanced. And it goes all the way back to 2003 when we did the Part D program. And we said that the government, HHS specifically, cannot interfere in the negotiations that happen between Part D plans and drug manufacturers and pharmacies. Right? This is the non-interference clause. And people say, well, Medicare can't negotiate, which they conflate into meaning no one's negotiating, so you're getting a raw deal. You're getting a bad price or a big price on your drugs, right? The problem is that for a long time people argued we should get rid of that and let Medicare negotiate, okay? Well, that would save exactly $0, because these Part D plans, and there's about 900 of them in the marketplace this year, go out and aggressively negotiate. That's how they get a good deal for the people who sign up for their plans. It's how they make a buck, right? So they go out and they get, on average, about 25 to 30% discounts on drugs. But because Medicare and repealing that clause scored no savings, folks had to think of a way to make it score savings so that we could say Medicare negotiation works, okay? So the answer was international reference pricing, or IPI. So we're going to now allow Medicare, and more specifically Seema Verma and I guess Alex Azar and ultimately President Donald Trump, to negotiate drug prices on your behalf. And I'm told Donald Trump's a great negotiator. That's what I've heard. He wrote a book on it. So they're going to go out now, instead of the plans, they will go out and negotiate the drug pricing discounts. And they're going to pick initially a couple dozen drugs, and they could go higher over time, but like they'll negotiate a better price on those drugs. Well, these are products that don't have competitors in the marketplace. So these are, think about what these products are. These are the exciting therapies around cancer or cystic fibrosis or sickle cell or some of these other gene therapy type products, or exciting advances in cancer and other things. They're not the Me Too drugs, right? So we're going to say, for those drugs, we're going to look at 6 countries. We're going to average the price out in those 6 countries, and we're going to pay you no more than 1.2 times the average, okay? CBO said almost all drugs will come in at about 1.2 times. So it's price setting, right? And I realize this is a long explanation to get to where I need to go. Or if there's no prices available in those countries, then it'll be 85% of what the manufacturer puts out as the average price. Okay. So what this is going to do is completely send risk in the market for unmet needs through the roof.
Right.
The money is not going to go into cures for CF. It's not going to go into cures for sickle cell. It's not going to go into cures for cancer or any of these other products. It'll go into the 10th Lipitor. Okay? And so we're going to get this wonderful byproduct because it's not just the quality that's being applied, it's making the economics completely unworkable.
That's right.
Okay?
Right.
So you got a double whammy for the patient with a disability or with a dread disease, saying not only is like the quality being applied and it's discriminatory against me, but I can't even get the product because it's not even being made anymore.
Right.
This is crazy, right? We as a society should want more products that cure people and keep them out of the hospital and let them go on their merry way and live their lives versus not having access to treatment so that they go to the ER, they go to the hospital, we spend a lot of money as a society, people get sicker, and we end up with less life expectancy in this country. It's exactly the opposite of where we want to go. So IPI, in my opinion, is just nothing more than a rationing machine that goes back to some old politics that started in the 03s, 2000s, early 2000s. You were around then. When you said I was an old friend, I assumed you didn't mean my age. Relative time that we knew each other, right? So anyway, the point is that we're very opposed. We see it as a bad scheme. And what is the experts have said, you're going to get a lot fewer products on the marketplace, 100 or so fewer products with about 4 years less life expectancy as a result. We don't need that kind of policy. We want something that's more affordable and more accessible.
Isn't it fascinating? Because I think about 10, 15 years ago, we were so critical of the lack of focus on rare diseases and diseases that have no treatments, and there were too many Me Too drugs coming on the market, right? And now we're in a position where it's different, right? Now we have treatments emerging for diseases that had no treatment before. So anyway, so what you're saying resonates. And speaking of that, so Stu, I wanted to ask you a little bit about Alzheimer's, because you've specifically written about the implications of QALYs and access to care for seniors. And so when I think about international reference pricing, one of the conditions that I think a lot about is Alzheimer's. Mm-hmm. And with this recent announcement that there may be an Alzheimer's treatment coming to market. So can you talk a little bit about your views in terms of how this affects seniors, aging, conditions related to aging?
Sure. I mean, when we talk about that, I just want to put out there it's important from our perspective to include people with disabilities, because there are a lot of people with disabilities, thankfully now, that are aging. And I am hopeful that our communities will continue to just grow in the work that we're doing together, because that's really important. I think that the opportunity that's in front of us now with a possible approval for an Alzheimer's medication is, not only exciting just because of the implications of having a potential disease modifier, but also because of the ability to kind of blow a hole in QALY. Because the fact of the matter is, when you're talking about people with Alzheimer's, you're talking about the oldest old. And so to really have to sort of push the argument that people who are older just aren't worth it is going to be awkward. And I do think that there's a good opportunity to sort of raise these issues with ICER and with QALYs in general, because Alzheimer's is so prevalent in the United States, throughout the world. To basically say that because you've worked your whole life, paid into a system, paid your taxes, and now you get to a point where you have cognitive impairment that develops into Alzheimer's disease. Sorry, thanks for playing. That doesn't come off that well. Mm-hmm. And QALYs really do discriminate based on age. If you have somebody who's 30 versus someone who's 60, mm-hmm. you give them a curative treatment, they're projected to live till 80. The fact of the matter is, it's like 150%, I think, more cost effective, if I'm doing my math right, for the 30-year-old than the 60-year-old, and that's how QALYs work. So older people, people with disabilities, a lot of veterans, they're just not worth it. So this Alzheimer's treatment conversation is going to force this issue probably in the next year or two. If it's not Biogen's drug, it's, there was a recent approval in China that's likely to be considered in the United States. So something is coming. And the one other point that I just want to make, because I felt that Dr. Bailey and Siri just had such compelling arguments around ICER and your experience with ICER and how it feels like you're just sort of being used, is I would say the same thing about the companies that belong to ICER and that engage with ICER. It's the same thing there. And I just want to encourage the companies to recognize that even though ICER makes themselves out to be the only game in town, we don't have to play the game. And it sends a message to the patient community when you belong and you pay your dues. And I understand you want to keep your friends close and your enemies closer. But I really want to encourage the companies that are out there that belong to ICER to not belong. And to send a message that what's happening is not okay. It's not okay what's happening to the patient community. And it's definitely not going to be okay for people with Alzheimer's disease.
That's very helpful. I'm just thinking too about, because Anna, you were making the point about the United States not having comprehensive policy. And Joel, you might be able to answer this. Thinking about how would you apply then a QALY ban that would also extend to international reference pricing? Because when it's been considered, when we talk about QALY bans, we don't extend the idea of a QALY ban to something like international reference pricing. And so I feel like on the Hill, there is like a QALY ban, as you described, Sue, in HR 3, but it's not. But it doesn't actually have the impact that it would, because you're just going kind of. It's like there are all these backdoor ways of getting to the same point.
Yeah, I think that was a concern with this bill, and I think that many people thought that it was a backdoor way of allowing the QALY to impact prices here. Now, if you look at, if you just Google how are international drugs priced, they will say, yes, the QALY is used, but they'll list 9 other factors that go into that. And it's easy to argue then that, it's not just the QALY. They look at this, and they look at this, and they we just can't pinpoint. And I think that made the argument a little harder to make for this when this bill was being developed, even though people were trying to explain that this really would allow the QALY to impact our prices. I think that there is a disconnect as well. We have certain policies, certain bans here, like on Medicare, but it seems like when they're pursuing legislation on the Hill, they're not considering what we have in place right now. They don't have someone that's coming and saying, this is all the stuff we do right now.
Okay.
And this is the stuff that you need to consider in your bill, right? There was some kind of disconnect here that's hard to describe, and I think that that's one of the things that we're concerned about, that we're not able to make the legislators understand, first off, the limitations of the QALY based on United States disability rights laws, the limitations that imposes on it, and we can really use that as leverage here. To say this is, the conversation before it got into the Affordable Care Act was long and intense, and it ended up in there for a reason. It was a recognition that this was discriminatory.
Right.
Okay, that has not changed. It still is discriminatory. No matter what ICER says, no matter what that position is, they are talking in circles around something that we know exists and that is true, that is discriminatory.
Yeah, I think the problem is that the qualities are endemic to the foreign pricing models. So if you're referencing those foreign pricing models, you're bringing that into the U.S.
Yeah.
structure. That's the issue.
Right.
So, from my perspective, outside of not just, we shouldn't do IPI in the first place, just
Just don't
principle.
do it. There you go.
I think if we agree that qualities are against U.S. law and U.S. trade law is about extending, aspects of U.S. law that we find desirable, we ought to tell the U.S. trade representative to go out and negotiate with these countries to eliminate qualities as part of their pricing mechanisms overseas. So, in other words, as part of our trade policy, USTR is going overseas to England to say, you use qualities in your pricing stuff, that's against our U.S. law.
Right.
You ought to get rid of qualities in your law, and then we can start doing better trade deals. So, but, this is just one guy thinking on a stage.
Well, it makes me think about the disability treaty,
But that is consistent not only with U.S. law, but it's consistent with U.S. values. So rather than, again, I said at the
Yes,
beginning,
you're right.
with Trump, instead of saying we're going to import price setting into the U.S., why aren't we exporting our capitalism or our values into the foreign systems to say, no, your system needs to work better?
That's a really useful perspective.
So-
Thank you. So why don't we do some Q&A and yes.
So many questions here. So I'm Ashley Valentine. I'm a civil law advocate from the community, so we see Dr. Bailey here. I'm curious your thoughts about, when did the focus leave transparency in coverage to now international drug pricing and just looking at the list price? So, oh wow, it's a microphone. Hey. So what's interesting about sickle cell disease is that we're so blessed right now. We have new treatments that are available, but we're living out everything you're talking about in real time. And Dr. Bailey mentioned a treatment that got approved in 2017. When that treatment was approved, the headlines for us is insurance won't cover the drug.
Right.
And Blue Cross Blue Shield is denying coverage. Coverage is not happening. They're not being covered. Under the ACA, I got to work on the back end, and they were talking about more transparency in the formulary decisions. Now, these new treatments have gotten approved, and the headlines are price is set too high. But what's missing out of that is, we're not talking about how the wholesalers get a cut, or how the PBMs get a cut, or how the payers get a cut. So, when did the conversation in your opinion shift from, let's talk about coverage and payers and PBMs to this international pricing conversation?
I'll answer that. I think that's a really good point, and one point that we've been, trying to raise throughout the debate is, if you look at sort of total costs of care, I mean, even sort of letting go, like how do you look at drug pricing and the drug pricing issue? Just if you look at sort of hospital costs and, things that are kind of going up at much higher rates, it's like we're not even going there yet. So it has gotten, kind of very concentrated on drug pricing, and not even necessarily on what are folks paying at the pharmacy counter, but on the list price, which really has, to your point, very little to do with what patients pay at the pharmacy counter. So, we've been working with a lot of other groups that are, have a lot more experience than we do in this space around out-of-pocket limit and the whole issue of smoothing, like sort of real world issues that folks face when they're looking at their coverage, if they have a deductible at the beginning of the year, and kind of what is the real thing that folks are experiencing. And you're absolutely right, I mean, the rebate issue, and there is some of that in these proposals with more transparency around it. I'm hoping that that's sort of a first step to revisiting what's going on with rebates and whether or not it's possible to pass those through. So there's a lot more, and this is a complicated problem. It's not going to be solved by just, oh, let's just do IPI and that'll take care of everything. There's a trade-off, and you can't just do one idea and think that that's going to solve everything, because it's not.
I think 2016 was a watershed year. You had people starting to talk about foreign freeloaders,
Oh, yeah.
right? And I think that changed the dialogue in a significant way because people had big microphones. But I think those other issues that you mentioned are still on the table. I don't think they've gone away, but it's they're competing for some oxygen. So. Yeah,
Do we have any other questions from the audience? Oh, go right ahead, please do, because you had such a large part, I know, in helping with the report.
So this is less a question and more of a comment. I basically know what's going on here for various reasons of my own. My comment is more that if you're going to go toe-to-toe with ICER in a fight, you can't come in with a substandard knowledge of why the quality is discriminatory. Like, the quality is a ridiculously complicated subject. Somehow I, the person who got a C- in math in high school, had to figure out what exactly a lot of the more complicated economic reviews of it were actually saying, which was no easy task, but the fact is, somehow or another, I did, and it's important to have the background that it isn't just that the quality is discriminatory because of how we use it, although that's a big part of it. It's that the very way that the metric is actually designed makes it pretty much impossible for it not to be discriminatory. Right. And once you know that, it becomes a lot easier to contend with some of the things that are coming out of the mouths of our opponents. If you know that, you can push back. Right. You can ask them more directly, well, how? How would you design this in a way that isn't discriminatory?
Good point. Excellent point.
That is an excellent point. Well, thank you. Oh, sorry, Madeline. Well, one more, and then we'll.
Good afternoon, Marianne Sterling from LivePact, and I share Sue's concern from the standpoint of the Alzheimer's community. I have been an advocate in this community for 20 plus years, which is scary enough. I've had 3 out of 4 parents impacted by dementia. And I gotta tell you, there's a lot going on in the Alzheimer's community and a lot of excitement and probably well-founded about Biogen's new success. But I don't hear enough people talking about this topic. And it's a little worrying. And I think this is something that the Alzheimer's community in general should rally behind, understand this, and be more vocal about it, because we have legions of, fortunately now, legions of advocates, and a lot of them come here at least once a year to Capitol Hill en masse, and I think this is something that our community really needs to get behind, and quickly.
Thank you.
Speaking of Alzheimer's, 2 things. One, my mom actually died in 2015, December, of early onset Alzheimer's. So yeah, the majority of Alzheimer's patients are people who are like over the age of 60, but there actually are, believe it or not, young Alzheimer's patients who are unlucky enough to get a genetic variant of the disease in their 40s and 50s, and guess what? We have no idea why. Another thing to note is the NHS actually restricted access to some of the most basic Alzheimer's drugs to patients with mild forms of Alzheimer's disease, years ago. So in 2004, 2005 or so, when Aricept was first coming out, and Aricept is one of the most basic Alzheimer's drugs imaginable, everybody and their brother with the disease uses it, they actually restricted access to frickin' Aricept on the basis of quality adjusted life here, even though they found basically that the cost of a pill per day was the same price as a cup of coffee.
Right. Thank you. Well, I want to say thank you to everyone, and thank you for all the thoughtful questions, and thank you to the panel. We really appreciated having you here. Tony is going to wrap us up. Thank you, Tony.
To the panel. Okay. I've made all kinds of notes based on what I've heard. I think that this quals thing is creeping on us, and we're not fighting it aggressively like we should collectively. You know, there was an article not too long ago in New York Times Magazine that said, if you're 75 or over, you have no value. And that is creeping down from that statement into those of us with disabilities and particularly rare diseases. And so we need to get together and really organize it. How do we change that? One thing I heard, I'm a little excited about, I've always felt this, is that this is a violation of the ADA. And we need to develop that. We need to develop what we mean by that, because I'm willing to fight it. But we need to develop it. We need to have the good arguments and the solid arguments. And we then should get all of you together working with us to take that on and to educate certain members of Congress, both parties, but certain members of Congress, to help us do that. So I'm excited about what transpired here, because I think there's an opportunity for us to come together and fight it. Sarah will tell you that we've met with ICER. It was a rather interesting meeting. And we met with them and with CVS. And that would make it even more interesting. And we're still in the fight in regards to that. But in that discussion with with ICER, it was obvious that they aren't strong in their position. But we have to find the loopholes in that. And I'm excited about what I heard today, because I think there are there if all of you are telling us the truth, which I think you are. But I'm going to take advantage of what you said, and let's get together and let's fight it. So thank you very much for all coming. It's exciting. Thank you.
Thank you. Thank you.